At this time, I'd like to introduce our last speaker to delve more into efforts to reduce social risk factors. I'm pleased to introduce Carol Robbins, who serves as the Manager of Social Work at Arkansas Blue Cross Blue Shield, and she's joining us today to share their innovative efforts to engage social workers as partners in addressing some of the social determinants of health. Carol?
Thank you, Catherine. I'm so excited to be here and to be in amongst this wonderful group of speakers. And I think, what occurred to me is that we're all doing something in our communities or within our jobs or within our volunteer organizations to address what we now know are the social determinants of health that are really impacting access as well as just healthcare in general. So what I wanted to do today is I just want to talk to you a little bit about something that we're doing here in Arkansas Blue Cross and Blue Shield. Social work was not really on the scene at Arkansas Blue Cross until about 2012. And so I think in 2012 we got our first social worker. She was added to the case management department for the Walmart line of business, and she was, as you can imagine, quickly inundated. Then I think she was replaced a couple of times. Then in 2014 we added with the new Medicaid exchange program, we added the 2 social workers that were community-based to work specifically with a community-based case management program in order to reach that population. And then now we advance to the fact that we do have a separate department. We are within clinical services and population health. And we are, our goal is to make social work available to all lines of business. I'm happy to say that we have most lines of business covered at least on a consult basis here in 2018. This department has a manager, a supervisor, and then we have a total of 13 social workers. And then we also are taking on an MSW intern. Trying to get a great team that not only will bond with other teams within our enterprise, but then also out in the community as well. We have both telephonic as well as face-to-face interactions with our members. And I wanted to say that we've officially joined the fight. I think for the longest time, we have been working on a consult basis, usually from having an RN case manager, a nurse navigator, or a gap nurse that would identify someone. And typically what we do, we get a consult, we assess for social issues and their impact. We are sometimes able to educate members on any resources that are out there. But more importantly, we assist our members in trying to navigate their own community, and then also advocate for new resources, because I think we're all talking about that increased needs really prompt us all to come up with new resources or to identify new resources so that our members can have a better health outcome. We also explain their own benefits, and we tell them how to use them. When we certainly took on the Medicaid exchange program, we all know that now as Arkansas Works. We've done a lot as far as with education of keeping appointments with your PCP. When to acknowledge, the need for a specialist, utilizing, appropriate areas of care such as ER, urgent clinics, as well as PCP visits and, things like that. So that's typically what we have been doing just on a consult basis. And this slide is one that I wanted to share just to kind of let you know what began to occur to us, and that was based on the 2017 social work consults that we track. You can see that, in most cases, medical expenses and household expenses, in other words, financial assistance, was, certainly one of the major or two of the major needs, followed by, certainly food insecurity is a big one, and, of course, public benefits, accessing Social Security disability, SSI, knowing when and how to apply for that, knowing what the process is, what the wait time is, what you're supposed to do in the meantime, and then certainly transportation, was an issue. Again, these were based on social work consults that we were getting, and because we are nationwide as well as we have several national accounts as well as state level accounts, this is kind of all blended together. So then we began to look closer to home. And so what we saw really quickly, and what's been verified in several presentations, not just today, but in many that are topics of discussion now, Arkansas ranks number one in food insecurity, and that's just a horrible thing to us. You just don't think about it. You don't think about our kids being hungry, but yet there are several efforts in the community that we do things like cereal drives in the summertime to provide food banks with cereal and cereal bars and certainly funds for that. So that we thought, well, even on an enterprise level, how in the world can we help with that? One of the things that I will just let you know about but not really get into is just as an enterprise, we have set a goal of packing over 700,000 meals this year, and we are well on our way. We have 8 regional offices around the state with staffs, and of course each office is encouraged to get involved in their communities, to help out in their communities, and to be a source of resource for their communities. And so I'm happy to report that over 460,000 meals have been packed so far by employees and volunteers with Arkansas Blue Cross around the state of Arkansas. So certainly there's more to do, and I think probably an overall goal is really over over 1 million meals. But like I said, I think it certainly is a joint effort here with our employees that are out in their own communities, and certainly it's an honorable thing to be able to help your own community. The other thing we know as far as obstacles to care, and we've kind of identified, and I think somebody else had touched on it, and that is the mood disorders, substance abuse, and unrelated chronic illnesses, untreated, especially diabetes, are leading diagnosis for ER visits. And so that was something that was becoming obvious, and I think it appears to be that so in several lines of business that not only we work with, but it seems that way around the country, is that there are lots of overuse of the ER, and a lot of those reasons that they're there have nothing to do with just an illness or an injury. It has more to do with a chronic illness or behavioral health diagnoses. And of course, another thing on food insecurity is it's the most significant social determinant of health in the U.S. Having to choose between food or health care costs is certainly something that we probably, I know we have run across as far as with our members, and it's difficult to get those answers, sometimes from your patient. But when you do, like I said, there are several resources that we can offer as a social worker, but then also as a social work department, we are constantly looking for more sustainable resources. I believe Katie or Becky had mentioned about, that's certainly an important area to be concerned about. One in particular I really want to tell you about is We are we have looked at the Central Arkansas community. Our big base of Arkansas Blue Cross is located here in Little Rock. And in this central area, there are 3 major healthcare systems, and there are, an incredible amount of PCP offices and clinics and wellness centers and things like that are supplying healthcare here in this area. We worked with the ambulance service that provides emergency care here with their ambulance service and then their paramedicine service. In 11 of 2017 in November, we joined the case management or care management group here within the Blue Cross area, and also, we had medical directors involved. We had other people, from Blue Cross who were interested, project management, obviously. And we met with our local ambulance service that's called MEMS, and that stands for Metropolitan Emergency Medical Services. They have a coverage area of almost 194,000 people in Central Arkansas with, as I said, the 3 major healthcare systems. So what we wanted to do was to sit down with them and talk with them about something that they had come up with, kind of based on some things that had been happening in Colorado and even in northern Arkansas had been talked about, and that was a paramedicine program. So we met in November, began to talk about what they could do for us, what we could do for them, and we wanted to target our Medicaid exchange program, as I said, known as Arkansas Works. And a lot of times, with this population, they have government phones, they are very transient, they are sometimes living in shelters, have P.O. boxes for addresses, and so a large part of our problem in trying to provide even case management or social work services to these folks is to find them. And also the fact that they have an unusually large number of ER visits a lot of times for various reasons. So certainly MEMS had also had that type of problem. They had looked at their ambulance usage and, based with the fact that there is a lack of transportation, and of course public transportation has a limited number of hours. So you have a lot of the Arkansas Works members who would go to the ER for their medical care, not necessarily always appropriate. So we partnered with MEMS, as we call them, to provide this paramedicine program to target our members, and they cover about, I believe it's 4 counties and maybe parts of a 5th. And we certainly, went to address the targeted area or the targeted members in the Arkansas Works membership that overused the ER, so they had a huge number of ER visits and even possibly inpatient visits. So we looked at that category. We began to identify those patients, and then we began to refer them to the MEMS company, and we began to meet with them, one, to help identify obstacles that were in the way of, them getting adequate care, trying to determine what their needs were as far as looking, why are they going to the ER? And then, how else could we help? Was there a PCP access problem? Was it transportation? Was it food insecurity? And so with that, our agreement was that the paramedics would not only help find these members, but then make a first visit, announce our partnership, and then try to go and see them in the home and do an initial assessment. Within that assessment, it was a medical assessment as well as a home safety assessment. And a lot of times these same people were people that the ambulance had also identified as misusing or overusing their ambulance services. So they performed the home assessments. Like I said, they did a very thorough job, wonderful information, certainly provided corrected contact information. And then as we had weekly meetings, they would make a referral back to the case management department that covered for the exchange, for the Arkansas Works, and also the social work team. And basically what we wanted to do at that point is we set up a team of an RN case manager and a master's level social worker, and we wanted them to go above and beyond what we had generally set out. We really wanted more hands-on. We wanted them to go, above and beyond as far as accessing services, making phone calls for them, finding food if that's what it was, or just basically trying to figure out what's bringing you to the ER and what's not being met, what kind of questions you still have. So we started doing that. We set out the goals of the program. We called it a pilot of a pilot because at this point we didn't know what outcomes to expect. But we knew that we would start small because we didn't want to overwhelm our current system, and we were using staff that obviously was also assigned to the rest of the Arkansas population, Arkansas Exchange or Works population. So we certainly, wanted to start small and to reevaluate. But these on this slide are 6 of the goals that we really had in mind when we started this program. And that was just to define the population. Certainly not being able to find them, as we all know, when we're dealing sometimes with people, they prefer a homeless status, and that may work for them until they get sick. They may have substance abuse problems, but then after a while, it then develops into a chronic illness with, liver disease or, something like that. So, number 2 was to define the social needs that impact the health outcomes and healthcare utilization. And again, that goes without saying, we've talked about that already today. And to define the resources needed. This population as a whole is very fluid. This population is very transient. Again, communication is usually by a government cell phone. Did we need to text? Did we need to, work on transportation? Did we need to partner with somebody else? To really get down to the refined needs and see how that would benefit, and then to look at the return on investment. So certainly that would be something that we could then bring to our leadership, who were very receptive, to any sort of ideas that we may have. We also wanted to increase the case management and social work team engagement of the target exchange population. We wanted to have them, again, like I said, go above and beyond to be able to, certainly focus on, stepping out of that traditional role of telephonic or, just an initial visit, build on that initial visit, the assessment that we got that the paramedics did for us, and then go from there. We also wanted to increase PCP utilization and to decrease inappropriate use of the ambulance and the ED. So here we go. This, I don't know if you can see, this is the actual chart of what we found, the MIMS participant social work triggers. When we were identifying before, we were looking at things like medical care expenses, in which that's still a large group. But as you can see, mental health and substance abuse was probably even more so. So, I mean, even though our consults in 2017 were addressing a lot of these, as you can see, depending on the population, it certainly was shifting a little bit so that, now we're talking, a lot more about behavioral health, and certainly, Arkansas does have its issues, with our mental health services, and so that, would certainly give us something to go back to leadership and, maybe have some ideas on how to partner with someone to provide those services as well. But this was the information that, having MIMS first make that contact and then to have our teams follow up, certainly we're able to address and provide resources for. Our lessons learned, well, we have to utilize appropriate PR and education to introduce the pilot. We had to end up developing a big, large postcard kind of thing to show our joint effort. Certainly this population can be very suspicious of people that are wanting to come in and help, especially, with an ambulance service appearing at the door. So we had to work more on that, and that's still in progress. We needed to refine the assessments for the Medicaid population. A lot of home assessments are actually based on safety for the elderly. And interestingly enough, we've kind of looked at several different assessments from some of the other rehab, home health, and those type of services. And so we're working on a more current assessment that will address safety from gun, illegal drugs, that type of thing in there. And we also are trying to link with additional enterprise efforts. One of the things we do well here at Blue Cross is we try to communicate with each other. We have our divisions, and we try to communicate with each other and make each other aware of what the different programs and what different populations we're trying to access, so that we can, conserve our energies and conserve our people to, work on several things at one time, but not to duplicate those services. And certainly lessons learned to find how to address the social determinants of health at the individual and population levels. We often say that we're a market of one because, we deal with individuals one at a time. And even though we can aggregate data and we can, make determinations of possible areas of need, we still start out, it's one member at a time. Okay, and then one of the things we're all very happy to say is that we do have a very positive outlook here at Arkansas Blue Cross. Social work has been very well respected, has been welcomed, and has been sorely needed. And from our leadership on down, has been very much in demand, either on work teams or in different lines of business that we actually bring on. And so I'm happy to say that I think we found a very comfortable home here at the health plan. Certainly, some of the things I'd like to see done, and I think our whole team would, as well as the backing and support from our leadership, would be to expand the program to be able to address more of these partnerships, to identify some of the different types of social determinants, and then work on solutions. And certainly the next one, partnering with community-based organizations to increase our reach, our effectiveness. We have a lot of rural areas in Arkansas, and certainly we would like to, help mobilize them, because I'm sure we all hear this is, go fix the problem, but don't always, count on adding staff. So I think partnerships, and plus you have your buy-in with those community-based organizations. Also, work with other pilot projects such as Matrix. We've engaged Matrix for some of the same population, as well as some of the Medicare population that we work with in the fight for better health. And then certainly, we look forward to more bonding of social work and case management teams to be able to address the holistic person. clinical as well as social needs. I've often heard Medicare is clinical and Medicaid is social. And certainly, our work with the population known as the Medicaid buyout, the Arkansas Works program, has presented new challenges to our whole enterprise. All right. I want to thank you for having your attention today and giving me an opportunity to really tell you about our programs and be, and know that also we are all kind of joining in this fight together, I believe, from the speakers that you've had before me. So, Catherine, I'll let you have it. Here is my contact information. And also just wanted to reference some of the places I've got this great information. Okay? Thank you.